شايفين المحاضرة ها؟
نعم.
إن شاء الله. نبدأ بإذن الله.
ايه تمام حكي.
That by 2030, the problem will raise considerably, up maybe up 20-25% increase, probably due to driving comorbidities for the risk of stroke. And the prevalence of stroke increases
صوت مسموع؟ صوت
with
مسموع؟
advancing age, and both in males and females.
Yeah.
The problem
لا، ما
is
كان مسموع.
والله يا حكيم. Almost
ما كان
800,000
مسموع،
strokes
but-
a year in the U.S. On the right, you can see the stroke breakdown. So we're not going to really focus on hemorrhagic strokes, but rather on ischemic strokes in this next discussion, and in particular the non-cardioembolic strokes, which make up roughly about 2/3 of ischemic stroke. Understanding the etiology of the ischemic stroke is really central importance in determining the best treatment options for those patients. And again, we're talking about non-cardioembolic ischemic stroke, and the most common etiology in about 40 to 50% of patients is atherosclerotic, and then followed by small vessel or lacuna stroke in maybe 20 to 30% of patients. It's critical, as we'll see in this discussion, because understanding the underlying pathophysiology and etiology may make a big difference in deciding on the appropriate and best treatment for these patients in the acute presentation to reduce their risk of subsequent stroke. So I want to go over, just for that reason, the two main types of non-cardioembolic ischemic stroke in terms of the pathophysiology. And I think we're all familiar with atherosclerotic disease. It's a non-focal disease, a mostly system disease, manifesting in any vascular bed. And clearly, the fibrous cap, which is encapsulating the thrombotic atherocore, if it erodes or ruptures, exposing the prothrombotic plaque contents, that's going to trigger platelet activation, aggregation, and thrombus formation, the formation of a platelet-rich thrombus over the disrupted culprit lesion. Now, this thrombus formation may result in either transient progressive occlusion at the site of plaque disruption, or more commonly, in distal embolization of a platelet-rich thrombus, precipitating the TIA or acute stroke. Now, one important concept to bear in mind is that platelets continue to adhere and aggregate at the site of the vascular disruption that led to the index event. And this thrombogenicity persists until the culprit site of vascular disruption heals. And it is this thrombogenicity that drives the risk for subsequent stroke early on after the index event, literally within a matter of days. The second most common etiology is small vessel lacunar disease, and it differs significantly in terms of the underlying pathophysiology. And so we can see here that the initiation and progression is one of aging, oxidative stress, mechanical stress. There are genetic predispositions. Comorbidities such as hypertension and diabetes drive the risk. But the hallmarks are endothelial dysfunction, blood-brain barrier degradation, and the vessel pathology, therefore, is very different from what we see in atherosclerosis, and so is the rheology, the environment in which a thrombus forms. And so with lacunar strokes, there's stenosis, there's subsequent thrombosis of small penetrating arteries and occlusion with a very different type of thrombosis leading to vessel occlusion.
الفكرة هنا هو يشرح أنه الجلطات الدماغية أحد المسببات الرئيسية للجلطات الدماغية يا أما large vessel disease وعاء تضيق بالوعاء الكبير مثل carotid disease أو intracranial تضيق بالأوعية داخل الدماغ أو خارج الدماغ. هذا السبب الأول. السبب الثاني small vessel disease، أوعية صغيرة تتضيق وتتسكر تسبب الجلطة الدماغية. إن كانت small vessel disease ولا large vessel disease، الصفيحات تلعب دور رئيسي بتراكم الصفيحات يا أما بالوعاء المتضيق يا أما بالوعاء الصغير. وهنا تأتي أهمية معالجة والوقاية من الجلطات الدماغية بمضادات الصفيحات.
And so we have been aware of the central role that platelets and platelet activation play in the index event and the subsequent risk for stroke. And there's clearly evidence tying the degree of platelet abnormality and activation to the risk of subsequent stroke. So in this data, for example, we can see that the expression of P-selectin on the surface of circulating platelets in patients who have presented with acute ischemic stroke or TIA is directly correlated and increases significantly in those patients presenting acutely with stroke and subsequently over the course of 3 months. So P-selectin is a marker of degranulation, and so there's a certain percentage of circulating platelets that are abnormally activated in these patients prior to and after at the time of their stroke
نشاط
and
الصفيحات
afterwards.
يزداد بوجود الجلطة الدماغية
Also, we
بحسب
see
هذه
evidence of
الدراسة.
normal platelet reactivity. So there's evidence of activated platelets, and those platelets have a different phenotype in that they are hyperactive in their response to arachidonic acid and ADP in these studies, looking at stroke and TIA, again, acutely and over a period of 90 days afterwards. And so this platelet aggregation stimulated by ADP is hyperactive in the first 24 hours for a time period afterward. And this persistent elevation of platelet aggregation stimulated by ADP has been associated with an increased risk of subsequent stroke. Now, we were distinguishing two types of pathophysiology initially, atherosclerotic disease and that etiology versus small vessel or lacunar strokes. And we can see that there's a difference in terms of platelet activation in this study by Proden and subsequently on the right, a study more recently by Kirkpatrick. And so what we can see is differentiating between the etiology, the control group versus patients with a lacunar stroke versus patients with large artery atherosclerotic stroke, that there's a significant increase in abnormal platelet phenotype, hyperactive platelets, compared to controls in those patients with atherosclerosis. But we don't see that in the patients in this study who presented without an atherosclerotic mechanism, but rather with evidence of a lacunar syndrome. And on the right, again, the extent of platelet abnormality, hyperactive behavior, was directly correlated to the risk of subsequent stroke early on. You can see the time course over the course of 4 weeks, really, most of the events are accruing. And those patients in the highest tertile of abnormal platelet activity suffered the highest risk of subsequent stroke. So after an ischemic stroke, patients continue to have increased platelet activation, abnormal platelet hyperactivity, which increases the risk of recurrent stroke. This persistent elevation of platelet aggregation in response to ADP is a marker and is associated with increased stroke recurrence. And of course, there are patient-related factors that exacerbate this platelet phenotype. Large artery atherosclerosis, as we just said, is one of them clearly, but so is diabetes, for example. All of these are associated with a phenotype, a platelet phenotype of hyperactivity in the setting of acute ischemic stroke with an underlying atherosclerotic etiology. And so that's a keen insight, I think, in terms of deciding about what therapy may be appropriate in treating these patients. Now, the current guidelines have recommended 2 types of dual antiplatelet therapy, and that's based really on evidence that is accumulated over nearly 10 years since the Chance trial in 2013. Aspirin has always been the basis of antiplatelet therapy for patients with stroke. And with evidence from Chance and Point, as we'll see, there's reason to increase that platelet inhibition, and dual antiplatelet therapy is superior and recommended over aspirin alone in the acute setting for all patients presenting with ischemic stroke. Now, there are 2 P2Y12 that are now in the guidelines, and ticagrelor is there on the basis of the recent Thales trial, and as I mentioned, clopidogrel for that other evidence. But there is no head-to-head data comparing ticagrelor and aspirin to clopidogrel and aspirin in patients presenting with acute ischemic stroke or TIA. Now, as a clinician, I know that it would be very nice to have this conundrum solved because there could be theoretical advantages and disadvantages to either dual antiplatelet therapy with ticagrelor or clopidogrel.
Yeah.
And so what I want to do is go over some of the theoretical advantages of both and disadvantages of both, and then look at the data that really drives the evidence for the use of agent in treating patients with acute ischemic stroke and TIA in combination with aspirin.
So الفكرة هنا انه بالاكيوت اسكيميك اتاك بالجلطه الدماغيه او النشبه الدماغيه المؤقته بيصير اكتيفيشن للبليتلت للصفيحات بشكل كبير جدا جدا، خاصه in a large vessel disease، تضيق بالشريان السباتي او تضيق داخلي بالوعاء، بيكون نشاط الصفيحات عالي جدا جدا وغالبا خلال الفتره الاولى، وبالتالي استعمال الدول مضادات صفائح 2 اسبرين مع بلافيكس بالفترة الأولى من النشبة الدماغية المؤقتة or aspirin مع تيجيكلور. aspirin مع تيجيكلور يستعمل كثيرا في القلبية، وحاليا بلشنا نستعمله بالستروك والنشبات الدماغية. له فعالية في الوقاية من حدوث الجلطة الدماغية أو البروجريشنز أو تطور الجلطة الدماغية. هون هلا بعدين حيحكي على الدول انتبليت الاسبرين بلافيكس واسبرين انتيجيكلور.
So to begin with, not all P2Y12 inhibitors are the same. Ticagrelor is a CPTP, so it's a different chemical class, whereas clopidogrel is a thienopyridine. And that has implications in terms of pharmacokinetics and pharmacodynamics. For one thing, ticagrelor does not compete directly with ADP at the binding site, but rather binds to the P2Y12 protein and shuts down signaling when the agonist ADP binds to the site, whereas the thienopyridines compete with ADP directly. Ticagrelor, being a CPTP, is active without metabolism. So the drug you take and its metabolite are active and equally potent, whereas the thienopyridines, clopidogrel, need to be activated before they can inhibit the platelet at the ADP receptor. And this activation for clopidogrel is dependent on CYP2C19, as we'll see in a minute, whereas for the CPTP ticagrelor, it doesn't require metabolism for activation. It's metabolized through the 3A4 pathway, and therefore its pharmacodynamics are independent of CYP2C19 status. I'm sorry, there we go. And so this cartoon depicts the pathway for clopidogrel activation, and the effectiveness of clopidogrel is really dependent on the conversion to the active metabolite, primarily by CYP2C19. That second CYP2C19 dependent oxidation step, about 85% of that activation goes through that step. And there are very common polymorphisms of CYP2C19 such that anyone lacking an allele coding for CYP2C19 will have a difficult time, if not impossible, for them to activate clopidogrel and have it work. And some recent data that we'll go over shows possibly the implications of that. Whereas ticagrelor, as I mentioned, is active without having to be further metabolized to inhibit the platelet. Now, being a CPTP, again, it binds reversibly. Ticagrelor binds reversibly to the ADP receptor, whereas clopidogrel, the thienopyridine, binds irreversibly. That has implications when you consider that in the setting of acute ischemic stroke, platelet turnover is increased. So there is a higher proportion of circulating platelets with an immature platelet morphology, phenotype. And they tend to be reticulated, larger, and also hyperactive. So they produce more thromboxane in response to stimuli, have higher thrombotic potential than mature platelets, and the fraction of immature platelets increases. So the significance of that is the mean elimination half-life and the bioavailability. So ticagrelor is taken twice a day. It has a half-life and bioavailability of 8 to 12 hours, whereas clopidogrel, the active metabolite, has about 30 minutes to run around, find your platelets, and inhibit them, and then clopidogrel is gone until the next day. And if you've been getting into steady state, you'll achieve steady state platelet inhibition, but you won't be inhibiting those immature platelets that are coming out 24/7 from the bone marrow that tend to be these hyperactive platelets that drive risk for subsequent stroke. And what we see here is the IC50, that dotted line going across, and you can see with BID dosing that ticagrelor maintains levels with its half-life and reversible binding and covering above IC50, inhibiting the platelets, whereas clopidogrel, having that pulse dose effect, is there, will inhibit and irreversibly bind the platelets that were available to inhibit, but any new platelets appearing in that 24-hour period will not be inhibited by clopidogrel because it's simply not around to do that. So those are the theoretical differences, and as I said, we'll look at it and consider it in terms of potential advantages and disadvantages, which is all we can do in the absence of any head-to-head comparison. These are the data that have driven studies, and the data from these studies that have driven the recommendations. So we have CHANCE, which was a comparison of clopidogrel and aspirin to aspirin alone in patients presenting with mild ischemic stroke, NIHSS scores of 3 or less, or high-risk TIA. It was a study done entirely in China, and it will have some implications regarding CYP2C19 status, as we'll see shortly. The POINT trial was more of an international trial. Same population, a different posology. So in CHANCE, patients received dual antiplatelet therapy for 21 days and then monotherapy, clopidogrel versus aspirin afterwards for 90 days. And in point, it was 90 days of clopidogrel and aspirin versus aspirin alone. Different safety endpoints, different efficacy endpoints in the studies. Socrates and Thales, as we'll see, are studies looking at ticagrelor and aspirin, ticagrelor versus aspirin in Socrates, and dual antiplatelet therapy in Thales. So let's take a deeper look.
هذا الجدول اللي عرضه مهم جدا 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 مهم. هذا بيشرح الانتي بليتلت ترايلز. هو بدأ بالمحاضرة بإعطاء أهمية البليتلت الصفيحات بالجلطات الدماغية والنشبات الدماغية المؤقتة وكيف يتم اجريجيشنز البليتلت، وبالتالي هذا بيؤدي لزيادة نسبة الجلطات والأشياء، وبالتالي إعطاء مضاد الصفيحات مهم جدا جدا، مهم جدا جدا، وخصوصا in a large vessel disease, carotid disease, intracranial disease, narrowing. مضاد صفيحات مهم جدا جدا. ومن ثم لابد من اعطاء الدول انتي بليتلت بالفتره الاول 3 اسابيع، اسبرين وبلاريكس يا اسبرين تيجيكلورز. بعدين شرح المين 4 ترايلز. التشانس ترايل هو ترايل صينيه بالصين، used aspirin and Plavix ل3 اسابيع بعد التي اي اي والماينر ستروك. البوينت ترايل هي ترايل in North America, use aspirin and Plavix for 3 months after a stroke or TIA. السوكراتيز والثالس ترايل. الثالث aspirin وتيجيكلور versus aspirin، والسوكراتيز aspirin versus تيجيكلور. بعدين يدخل من كل الترايلز مهم. هدول الترايلز is the main trials بالنشبات الدماغية المؤقتة.
At chance for a moment. This was a design of the study, a large trial. The primary efficacy endpoint was stroke, ischemic or hemorrhagic, at 90 days. And the primary safety endpoint was moderate to severe gustro bleeding. So patients were randomized, clopidogrel loading dose 375 daily in combination with aspirin versus aspirin alone for 21 days. And then from day 22 to 90, it was clopidogrel monotherapy versus aspirin. And clearly, there was a benefit, 8.2% versus 11.7%, with a point estimate of 0.68. That was highly significant, showing the benefit of aspirin and clopidogrel versus aspirin alone in these patients presenting with stroke. Now, the other important aspect of chance was that the rate of moderate to severe gustro bleeding did not differ between clopidogrel and aspirin alone. And that's somewhat counterintuitive, but it was 0.3 and 0.3. It's counterintuitive because you're comparing a more potent antiplatelet, seeing the benefit of more potent antiplatelet therapy, but you're not paying a price, sort of a paradigm violation. You're not paying a price in terms of bleeding. Now, the chance study was conducted in China, may not be generalizable to a broader population, in particular because of the safety. And that was brought out in a pre-specified analysis, as we'll see in a minute. This is the bleeding data, and you can see for gastro-severe bleeding down the line, severe, moderate, clearly no difference with dual antiplatelet therapy versus aspirin alone. And the reason for this may be in these data. So this was a pre-specified CYP2C19 genetic analysis in chance. The reason this was pre-specified is because the prevalence of CYP2C19 loss of function, any loss of function, heterozygote or homozygote, is about 60% in China. So much higher than it is here in the US, where that prevalence might be 25%. So clearly you can see in terms of the efficacy that those patients who are non-carriers, who could activate clopidogrel normally, did much better than the blue dotted line, the carriers who only received really not do much better than those patients on aspirin alone. And you can see intuitively, if they're not activating the drug and benefiting, they're probably not bleeding either. And the same trend obtains, remember, dual antiplatelet therapy was only out to 21 days. So to sort this out better and to decide on what might be an alternative strategy, the chance investigators did chance 2. And we're looking now at 6,412 patients, all of whom had CYP2C19 loss of function. And then they were randomized to clopidogrel and aspirin versus ticagrelor and aspirin. And it's essentially the same population in terms of demographics and in terms of stroke presentation as it was in chance. Again, 21 days of dual antiplatelet therapy, this time ticagrelor 90 and aspirin versus clopidogrel and aspirin. This is not a head-to-head comparison. Remember, all of these patients have loss of function. They cannot activate clopidogrel normally. A head-to-head, true head-to-head would be comparing ticagrelor and aspirin to patients with clopidogrel and aspirin when they can fully activate clopidogrel. That's not chance 2. And then they were on a monotherapy for day 22 to 90. And what we see is that there is a significant benefit. The cumulative index of the primary outcome, which was stroke, 7.6 for clopidogrel and aspirin versus 6.0 for ticagrelor and aspirin, out to 90 days. We don't have a landmark analysis for the first 21 days on DAPT, but we can see that the curves tend to separate early. Again, in this type of population, the events are accruing very early, and that there seems to be an ongoing benefit over the course of 90 days. But basically, all of the action and benefit seems to be early on in the first 21 days. Now, in terms of the efficacy, as we can see, stroke within 30 days was improved. Vascular events overall was decreased with ticagrelor, and ischemic stroke was decreased. Again, this isn't a head-to-head comparison, but it's simply telling us that if you can activate clopidogrel dual antiplatelet therapy, you will benefit from dual antiplatelet therapy. Ticagrelor would be and aspirin would be a good alternative in these patients. Now, in terms of safety, there was no increase in severe or moderate gustral bleeding.
بدأ بالبداية بالتشانس ترايل. التشانس ترايل هي ترايلز تمت بالصين لمرضى اللي معهم النشبات الدماغية المؤقتة أو النشبات الدماغية الصغيرة. المريض راندومايزد، يعني تم عشوائيا اختياره يا اما ينعطى اسبرين وكلوبيدوجريل لمده 21 يوم يا اما اسبرين الون. والدراسه اظهرت انه الدول انتي بليتلت استعمال اسبرين وبلافيكس بيقلل من نسبه حدوث الجلطات الدماغيه بنسبه 50% مقارنه بالاسبرين الون. يعني المرضى اللي بنحطوا على اسبرين بلافيكس، لود وذ بلافيكس 300 ولود وذ اسبرين 160، بعدين نعطى اسبرين 81 ملغ كل يوم لمده 3 اسابيع، وبلافيكس 75 ملغ 75 ملغ كل يوم لمده 3 اسابيع، بعدين اسبرين الون. هدول المرضى نسبه حدوث النشبه الدماغيه الدائمه بعد النشبه الدماغيه المؤقته قلت بنسبه 50% بحدود ال 4-5%، whereas المرضى اللي بنحطوا بس على الاسبرين نسبه النشبه الدماغيه بحدود ال 7-8%. هلا الامر الثاني شهاده تشانس 1. تشانس 2 ترايل درسوا بعض المرضى خصوصا بالصين عندهم نسبه عاليه لظهور المتحور، مو متحور، الجينيتك الايل جين بيأثر على استقلاب الكلوبيدوجريل، وهذا مكان فحصه يعني بالعيادات بس لسه بالريسيرش ترايلز. وبالتالي هذا الجين CB92 جين هذا بيقلل من استقلاب الكلوبيدوجريل، وبالتالي يصبح الكلوبيدوجريل غير فعال. في هذا الحال استعمال الاسبرين مع تيجاكلور is much better، افضل من استعمال الاسبرين مع الاسبرين مع تيجاكلور افضل من استعمال الاسبرين مع كلوبيدوجريل. اسبرين والتيجاكلور افضل من الاسبرين والبلافيكس او كلوبيدوجريلز. بالنسبه لنسبه النزف خلال 3 اسابيع نسبه قليله جدا 0.5، غالبا GI gastrointestinal bleeding. It's in both groups aspirin or aspirin blavix very much the same، يعني the same ما في ريسك، بس الاختيار الافضل للانتي بليتلت. اي حد عنده اي استفسار سؤال قبل ما نكفي المحاضره؟
0.3 and 0.3 with a point estimate of 0.82. Fatal bleeding also was not increased. So these are patients who can activate clopidogrel, see some reduction perhaps in ischemic events, but also have an increased risk for bleeding. And when you compare the two again, partial activation of clopidogrel, full ticagrelor, no difference in bleeding. Again, you shouldn't extrapolate and picture what might have happened in terms of safety if it was full clopidogrel versus full ticagrelor. But at least if you're taking this strategy, there's efficacy, again, without an increase in bleeding. A paradigm violation, it just doesn't logically make sense, but again, we're seeing that in stroke in treating atherosclerotic disease. And this is just showing us in terms of the consistency of the result. And the intermediate responders really drove the outcome. And again, in the US, the prevalence is about 25%, that there would be some loss of function. Again, much higher, about 60%. Now, in terms of platelet inhibition, the Prince trial showed that regardless of your CYP2C19 loss of function status, you still had more potent platelet inhibition with ticagrelor. That was the primary outcome, the proportion of high on platelet reactivity. So ticagrelor inhibited platelets to a greater extent and did so regardless of CYP2C19 status. So even in folks who were extensive clopidogrel responders, that phenotype driving clopidogrel metabolism, you can see for the intermediate and poor responders that there was greater platelet inhibition with ticagrelor and aspirin versus clopidogrel and aspirin alone. Again, without head-to-head data, we don't know where the sweet spot lies. We don't know how much platelet inhibition you need to significantly reduce and benefit the reduction in subsequent stroke versus the increased risk in bleeding that might precipitate. And these data from Chance and even from Prince really do not give us the insight that we need. And so we have to really think about the theoretical advantages and then getting back to the pathophysiology and the disease state as to what type of patient is experiencing greater risk because their platelets are activated to a greater extent. And this was an interesting post-hoc analysis from Chance. This basically is looking at glycemic control, and on the left, you can see again clearly the effect of CYP2C19 loss of function. If you can activate clopidogrel, you did a whole lot better than non-carriers with clopidogrel and aspirin, the dotted line on the bottom. And if you were a non-carrier, comparing them, aspirin and clopidogrel and aspirin is so much better. If you were a carrier of the loss of function, again, that on the left, we can see that the benefit starts to be lost. But look what happens to that great benefit in the non-carriers when diabetes or elevated glycated albumin is in the picture. So for those patients who have an elevated glycated albumin, a sign of increased glucose levels, you can see that the benefits of clopidogrel and aspirin over aspirin, even if you can activate clopidogrel, are lost. Again, it speaks to the platelet phenotype in diabetics. Diabetic platelets are hyperactive. All of that behavior that I mentioned, increased platelet turnover, hyperthrombogenicity, hyperreactivity, are true for diabetic platelets at rest. And in the milieu of platelet activation due to plaque rupture, those tendencies are increased even further. Again, all these data to take into consideration when you're thinking about the risks and benefit and what type of patient might benefit more than they're harmed. Just quickly with the POINT trial, again, clopidogrel and aspirin versus aspirin alone, the benefit seen 6.5 versus 5.0. But here, in a non-Asian population where the prevalence of CYP2C19 loss of function is lower, the rate of major bleeding was significantly higher. In fact, the SMB stopped the study for safety when the pre-specified safety threshold was reached. And the point estimate is 2.32 for severe bleeding, 0.9.
So هنا يتحدث على البوينت ترايل
versus 0.4. Low absolute rates, but nonetheless an increase. So the impression that we get from Chance is that clopidogrel and aspirin versus aspirin may not be harmful, that there's no increase in bleeding.
Loading issues, huh? Yeah.
May have been corrupted by the high prevalence of CYP2C19 loss of function, because we definitely see a signal here in a non-Asian population where the prevalence was much lower. In fact, in a genetic sub-analysis in POINT, they didn't see an association between loss of function because the numbers were too small. The confidence intervals are wide. And this is just summarizing the data that I showed you for bleeding. And the primary safety endpoint in major bleeding was really driven by systemic and not fatal and not intracranial hemorrhages, which is important for considering what type of bleeding events we're discussing, and maybe the type of bleeding exacerbated by aspirin, perhaps, and not necessarily by the P2Y12. And these are the data that I showed you. Now, one important thing from POINT is that I did a pre-specified analysis at 30 days. You can see clearly that most of the events, as they tend to do are accruing early. Therefore, most of the benefit was had early, and nothing really happens in terms of efficacy beyond 30 days, but they continue cumulatively to accrue bleeding events. And so really the recommendation for more potent antiplatelet therapy is about 30 days. We're sort of on our own beyond 30 days. Again, we don't have data for any of the agents really to tell us what to do after that point. But in this population presenting with acute ischemic stroke and TIA, it seems that the risk benefit starts to
آسف هذا التحميل عم
switch
ياخذ
over
وقت.
at about 30 days.
هون في أمر مهم لابد من نقاشه. البوينت ترايل والتشانس ترايل these are the major trial على يوز الاسبرين بلافيكس بالتي اي اي والماينر ستروك. البوينت التشانس ترايل they use اسبرين بلافيكس لمده 3 اسابيع بعدين اسبرين الون. البوينت ترايل هي النورث امريكان ترايل استعملوا اسبرين اول شيء استعملوا بلافيكس لود 600 مو 300 واستعملوا 160 اسبرين واستعملوها لثلاث اشهر 90 يوم بعدين اسبرين الون. البوينت ترايل اظهرت انه فائده الدول انتي بليتلت يوز للاسبرين بلافيكس فقط خلال اول 3 اسابيع. بعد 3 اسابيع لا توجد فائده من استعمال الدول انتي بليتلت اسبرين بلافيكس. السبب انه اول 3 اسابيع الصفيحات تتجمع وتنشط، بعد 3 اسابيع الصفيحات ترجع لطبيعتها. اضف لهذا ان البوينت ترايل نسبه النزف وغالبا جي اي بليدنج صارت بحدود 2.5% عاليه اعلى من 0.5% للاسبرين الون. بالتالي النتيجه التي تعرف من هذا الامر استعمال الدول انتي بليتلت اسبرين بلافيكس لود يا 300 يا 600. الجوري از اوت. انا اي لود وذ 300. استعمال الاسبرين لود وذ 160 استعماله لفتره 3 اسابيع فقط. بعدين مونوثيرابي اسبرين او بلافيكس بستعمله انا ل 90 يوم في حاله واحده فقط في تواجد انتراكرينيال تضيق بالاوعيه داخل الدماغ او تضيق باوعيه الرقبه. هي الفكره تبع التشانس والبوينت ترايل. الفكره الثانيه انه هي في طور البحث العلمي انه بعض المرضى عندهم مقاومه للبلافيكس ما بيقدروا يعملوا ميتابوليزم للكلوبيدوجريل اللي عندهم الاليل هذا 219C29 something اليل جينيتيك اليل which is genetic يعني عندهم نقص في هذا الانزيم بالكبد لا يستطيع استقلاب الكلوبيدوجريل. هدول المرضى بيستفيدوا من التيجاكلور اكثر ما بيستفيدوا من الكلوبيدوجريلز او فائدتهم بتكون ضعيفه. ريجاردلس لتعرف هالامر لازم يكون عندك هذا الجهاز. مستقبلا يمكن بعد 15 سنين بيتواجد هذا الجهاز بالطريقه العمليه. That's the two things, the chance and the point trial. beyond 3 اسابيع نسبه النزف تزيد. لا تعطي اكثر من 3 اسابيع الا في حال تضيق وعائي خارج الدماغ او داخل الدماغ. نمشي هلا على السوكرتي ترايل.
And that takes us to the Socrates Trial. So we had dual antiplatelet therapy early on, 21 days, 90 days overall. In Socrates with ticagrelor, the design ended up that we were looking only at monotherapy, ticagrelor monotherapy versus aspirin monotherapy throughout the period. And you can see again that events are accruing early. For the composite primary outcome of stroke, MI, or death, 7.5 versus 6.8. The point estimate is 0.89. It is not significant. The upper limit is 1.01. There were fewer primary endpoints observed with ticagrelor, but the trend did not rate statistical significance. There was no bleeding difference in rates of Plato-defined major bleeding between ticagrelor and aspirin throughout the 90 days of the trial. As we'll see, there was an interesting analysis, though. So this is the primary safety endpoint. There's no increase in bleeding between the two, though ticagrelor is, a more potent antiplatelet, is what the belief is. In terms of the exploratory analysis for ischemic stroke, 6.6 versus 5.9, just missing significance. The upper limit of the 95% confidence interval is 1. But for the exploratory analysis in patients who had atherosclerotic disease, now we see clearly in those with extracranial or intracranial stenosis, the benefit of ticagrelor over aspirin becomes far more pronounced and really vanishes nearly in those patients without evidence of ipsilateral atherosclerosis, intracranial or extracranial. So even with monotherapy, again, the underlying etiology suggests that where the platelets are driven and driving the risk, that inhibiting the platelets more effectively substantially reduces the risk because the absolute risk here is the greatest. The point estimate is 0.68, which is significant. But this is a subgroup analysis in a negative trial, and so it gives us good ideas for future studies, but there's only so much you can infer from this. This is true for the primary outcome and for ischemic stroke as well. This was an important insight from Socrates that really helped us rationalize and design Thales. So what we see here is for the patients who were on aspirin before they were randomized to ticagrelor alone, did a whole lot better if they were taking aspirin just prior to randomization. Aspirin is an irreversible inhibitor. Its effects last for several days. And during that critical early period after the index event, for all intents and purposes, they were on dual antiplatelet therapy. And this is a post hoc analysis, but they clearly did better. And that definitely indicated that in that early period, after an acute ischemic stroke, the platelets are driven, more effective antiplatelet therapy is beneficial, and that perhaps there is this critical period early on where decreasing the antiplatelet therapy might be appropriate. We can't compare these studies. Even a meta-analysis would be very tricky because the populations are different, the posology is different, the endpoints are different, both for efficacy and safety. And so again, the clinician trying to make a very important distinction and decision about which agent and which patient and when and for how long is really left to try and interpret these data on your own. And as I mentioned, Socrates gave us some insight into the design of the Thales trial. And what we were doing now is shortening the duration of intense therapy with dual antiplatelet therapy, but for only 30 days. And we also increased the acuity. So now we're looking at patients with high IHSS scores and with high-risk TIA with an ABCD squared score of 6. Patients greater than 40 years of age presenting within 24 hours. And 11,016 patients randomized to either ticagrelor with a 180 loading dose versus aspirin alone, and they were on 90 BID and aspirin versus aspirin alone for 30 days. The key exclusion criteria were intraarterial thrombolysis or mechanical thrombectomy within 20 hours before randomization, or any planned carotid endarterectomy that would unblind the patient in the study or stop the treatment drug for more than 3 days. Other carotid endarterectomy was permissible. any planned use of dual antiplatelet therapy.
Loading issues. So Thales Trial, Socrates Trial. Socrates Trial negative, aspirin versus Tigaclor. Thales Trial is positive, aspirin plus Tigaclor versus aspirin alone. The benefit is margin, is not as aspirin Plavix. التيجاكلور ما بعرف دكاترة القلبية بيستعملوه أكثر، نحن ما بنستعمله كتير. But it's an alternative في حال المقاومة للكلوبيدوجرلز. حرصا للوقت أنا بس هاخد عم فكر قرب للمحاضرة الأخير أو احتمال نقدر نكفيها مرة تانية يعني، بس في مشكلة باللودينج. بس تقريبا يعني هذا هي اغلب just one second.
Events were too low. There were fewer than 15 events, and we couldn't calculate a KM. But it does suggest that there's this real dichotomy. What we're seeing is the efficacy, absolute risk and efficacy is higher in the athero group, and the bleeding risk is higher in the non-athero group. Maybe it's three or less in patients who had subsequent stroke, and an overall decrease in disability for patients with subsequent ischemic stroke of 23%. So you're reducing the number of events, you're reducing the overall disability in this ordinate analysis by 23%. In those patients. And again, you can see in terms of the odds ratios that an NIH score of 4 or 5 had an odds ratio of 3.9 for predicting RS score of greater than 1 with subsequent stroke. And ipsilateral stenosis, the atherosclerotic patient had nearly a doubling of risk for subsequent disabling stroke with MRS score greater than 1. And this slide sort of ties those two variables together. So the presence of atherosclerosis, yes or no, is associated with a higher risk of having subsequent stroke and also a higher risk of disabling stroke and a significant reduction in the risk of subsequent disabling stroke in those patients with atherosclerotic disease. Again, we're hitting the proverbial.
So large atherosclerotic disease نسبة الفائدة من استعمال الأسبرين تيجاكلور أعلى بكثير من الأسبرين alone.
More potent antiplatelet therapy in those patients in whom the platelet activity is really driving their risk of subsequent stroke, whose arteries may not be as prone to bleeding, giving the overall pathology in the milieu in which they're being treated. That said, again, caveat, this is a subgroup. The p-value for interaction in that atherosclerotic subgroup is negative. It really gives us insight into perhaps future studies where we're looking at the duration and the
تعود هون.
intensity of antiplatelet therapy in acute ischemic stroke in patients with atherosclerotic disease.
بنت الحرام. بدي اخذها.
and Thales trials. Might it be time to change the guidelines?
اسف لتقطيع المحاضره بس من اللودينج. هلا انا المحاضره هي انعطت الاسبوع الماضي انعطت بالانترناشونال ستروك ميتينج about the use of antiplatelet بالTIA والماينر ستروك. انا من الويب سايت، يعني داخل على الويب سايت تبع الانترناشونال ستروك ميتينج، عندي ريجستريشنز دخلت عليها، بس بظاهر حسب الناس اللي عم تحضر المحاضره احتمال يكون عدد كبير، بس اي ثينك المسج واضحه. الدكتور اللي اعطى المحاضره هو احد المؤسسين لهدول الترايلز، هو احد يعني البرايمري انفستيجيتورز لديز ترايلز. المسج واضحه، اهميه البليتلت، الاكتيفيشنز تبع البليتلتس، استعمال الدول انتي بليتلت، الاسبرين بلافيكس، اسبرين انتيجوكلور، اسبرين الون، durations 3 اسابيع، ما في داعي لل 90 days except if the presence of large vessel disease. الاسبرين تيجوكلور لسه الجوري is out. I would not recommend it. Let's use just the aspirin Clopidogrel for now. بترك الامر مفتوح لاي سؤال.
دكتور ماهر، في سؤال على الشات الدكتور فيصل سأله، ممكن تقرأه وتجاوب عنه؟
تكرر قصة إصابة مريض باحتشاء دماغي يكون مريض سكري وضغط ولا يتوفر TBA. أشبه أمكلوبيدوجريل أو جليكسا عند قبول المريض في حال عناية، وهل مسألة الاحتشاء الدماغي الكبير تمنع إعطاء معين؟ إذا لم تستطيع إعطائه TBA أو TNK أعطيه أسبرين. بلشوا على الأسبرين بعد ما تعمل الطبقي الدماغي. الطبقي الدماغي تأكد ما في احتشاء، ما في نزف عفوا، تعطيه اسبرين. بتبلشوا على البيبي اسبرين. الدي في تي بريفنشنز لو مولكيولر ويت هيبرين، دي في تي بريفنشن جليكسان 40 ملغ بتحطوا عليه للوقايه من خسرات القدم، يعني خسرات الوريديه. الاحتشاء الكبير، اذا الاحتشاء كبير هنا المشكله اذا بدك تبلشوا على مميعات الدم مثل لايك ريفروكسبان او برادكسا او وورفرين، الاشياء نتيجه رجفان اذيني، هون بتنتظر لفتره اسبوع اذا الاحتشاء كبير، واحيانا اسبوعين، بس خلال هذا الاسبوع اسبوعين بتعطيه بس اسبرين، بيبي اسبرين. الاحتشاء لو كان كبير ما دام ما في نزف ينعطى حبة بيبي أسبرين بنحط عليها. اتأكد إنه الأسبرين في نوع للأسبرين أورال، في نوع من خلال المستقيم براريكتلز. إذا ما بيقدر المريض يأكل أو عنده عسرة بلع.
تمام دكتور ماهر، الله يعطيك العافية، رب يبارك فيك.
ما يكون بإجراء إيكو. نحن أحيانا مرضى النشبات اللي بنشوفهم بالإسعاف ما يكون بالإمكان إجراء إيكو الدوبلر للشرايين الثبات الفقرية. هون ما في مشكلة تعطي كلور.
دكتور إبراهيم، هذا الأسبرين عن طريق المستقيم متوفر عندنا؟
لا حكيم، ما متوفر أبدا، فهو حبوب نحن عم نلجأ للإنجي تيوب. أحيانا يكون إنجي تيوب.
إن شاء الله الطبقي في طور الشراء إن شاء الله. الأفضل إنه إذا الطبقي بنعمل CT أنجيو للأوعية. إذا صعب then الدوبلر access to the Doppler of the السباتي والفقارية والشرايين الفقارية مهم جدا جدا. إذا ما نعمل بنفس اليوم خلال 24 ساعة ينعمل، مهم جدا إنه ينعمل خلال 24 ساعة. أي سؤال، أي أسئلة أخرى إن شاء الله. حبيت أنا أشارككم يعني بمحاضرة يعني حديثة جدا جدا، بس المشكلة هو التقطع الإنترنت، تقطع اللود للمحاضرة.
تمام دكتور ماهر، ممكن هاي تتشارك على موقع السامز باليوتيوب مثلا، هاي المحاضرة نفسها ولا؟
المشكلة المشكله انه بس على الاكونت، هي المشكله. لو انه مثلا تتشارك على اليوتيوب، ما كان عنا مثل المحاضره الماضيه، انا عندي اياها على اليوتيوب، ما كان في اشكال ابدا. بس هي المحاضره من الانترناشونال ستروك ميتينج.
تمام.
يعطينا اياها الخاص بس.
الله يجزيكم الخير. ان شاء الله الشهر القادم
ان شاء الله.
ونستمر المره بالشهر بنعطي محاضره لاحد علماء الجلطات الدماغيه بالعالم، وانا بشرح المحاضره ان شاء الله.
ان شاء الله. الله يعطيك العافيه دكتور ماهر.
الله يجزيكم الخير يا رب. الله يجزيكم الخير. بارك الله فيك دكتور عبد الرحمن.
الله يجزيك الخير. شكرا جزيلا دكتور
محمد. الله يجزيكم الخير. السلام عليكم.
حياكم الله. السلام عليكم.
وعليكم السلام.